Good morning. Myself Dr. Gaurav Malvi. I am presenting a case of 38 years old female presented with hematuria since 1 year.
Is the hematuria painful or painless?
It was painless.
Is there any similar past history?
No.
And was there any passage of clots along with hematuria?
No.
It was total, initial, terminal, painless.
It was total. It was painless.
Oh. Did she seek any medical treatment for this hematuria?
Pardon?
Did she seek any medical advice? Did she visit a doctor for this hematuria?
Yeah. Sought an advice at private hospital.
Oh. Is there any such past history, or this is the first episode?
No past history. Past history actually not of hematuria.
Let me interrupt you at this point and try to jog your thinking process. Young lady, 38 years old, has no business to have painless hematuria with clot, isn't it? With clot, correct?
No.
With clots or without clots?
No, sir, without clots. Without clots.
Painless hematuria. When anybody has got painless hematuria, whatever the age, whatever the sex, whatever the country, what is the first condition that goes through your mind?
For painless hematuria, a bladder malignancy.
Don't say bladder malignancy. Malignancy. Be general. Malignancy. Right. Okay. Now, think back again. How many 38-year-old ladies have you seen or have you heard of where malignancy is the cause of hematuria?
Very rare.
It's not rare. Don't say it is very rare. It is not very rare. Right? But you put up your antenna and say, oh, 38-year-old lady with hematuria. So, if it is not malignancy, there must be some other reasons that you must think of. And when you think of those reasons, you will then begin to ask the appropriate history. That is what I am getting.
Is
so
there
still going around this hematuria business with clot, if she go to hospital, if she seek medical help, all that. You have to move forward in your thinking processes as to what could there be any other reason, and therefore the history appropriate to that cause.
Any history of lower unit tract symptoms and storage symptoms associated?
No lower unit tract. No lower unit tract symptoms.
Okay. Any history of weight loss of appetite?
No history of weight. No history of weight loss.
So there's no history of weight loss.
There is no history of weight loss. Okay.
There's no history of any swelling of the lower limbs. She does not have any storage glands or inviting glands. Only painless hematuria is the only symptom.
Can you tell me a few reasons why hematuria would occur in a young adult female apart from urological causes?
Have you heard of a term called cyclical hematuria?
Yes.
What is cyclical hematuria?
Endometriosis.
No, what is cyclical hematuria? The answer is not endometriosis. I want you to define cyclical hematuria.
What is the meaning, sir, is asking, of cyclical hematuria, not the etiology?
Hematuria episodes after they coincide with this menstruation.
Menstruation, right. So,
apart from gynecological causes, what are the other causes? Nephrological causes of hematuria in a young adult female?
Immunoglobulin A nephropathy.
Pardon?
Nephropathies, ma'am. Immunoglobulin A nephropathy.
Yes, very good.
What else? Common? Associated with hypertension, progressive.
You can change it also.
Yeah, this side.
Fibrous dysplasia, ma'am. Medial intimal hyperplasia.
But
Fibrous
hematuria,
dysplasia. What do you mean by
hematuria,
fibrous dysplasia?
hematuria is the prominent symptom. Hypertension may or may not be associated. Huh? RPGN. Okay, what else? हाँ? जोर से बोलो ना. Renal cystic disease.
Supposing she's got fits. History of fits.
Retinal granulomatosis is very common.
She's got a history of fits also. You didn't ask that, but I'm telling you she's got a history of fits.
Okay, yeah, if she has history of fits or seizures.
Some syndromes.
What syndrome?
Tuberous sclerosis.
Oh. So you see what I'm trying to drive at. When you have a young person like this with hematuria, don't just put your mind only over cancer, cancer. No, you have to think of other reasons. Remember, this is a clinical discussion. All right? At the end of the day, it may turn out to be some rubbish, whatever it is. We don't know. But we have to go on our thinking process. That's what history must be. So, female, don't ever forget looking at the gynecological system.
Sir, your voice is not clear, sir. It is muffled.
Oh, maybe you can wear the mask. Right. Is the volume up? Is it up there? Yes, okay. I was wearing the mask, I think. That's the reason. Anyway.
Okay, sir. Yeah. Now better.
No, what I was telling him is that you cannot just think of any woman with any urinary symptom. You must get the gynecological story correct. Not only gynecology, but also the obstetric history. Supposing she's had a serious cesarean section, and all these problems started after the cesarean section. What could be? Same thing. So the history will become paramount when you begin to think a bit laterally. What could it be? Can it be something else? So tuberous sclerosis, young lady, hematuria. Okay, carry on.
Hematuria was total, painless, intermittent, not associated with blood clots or tissue bits. No history of blood transfusion.
Go to the next slide.
No history of lithuria, pyuria, or dysuria. No history of urinary retention. No history of constipation.
You've done this also.
No history of weight loss or breathlessness, and no history of fever. No history of diabetes mellitus or hypertension. Patient is known CKD. Hereditary create is 2.3.
Has she been evaluated earlier for this CKD?
No, wait. This is an important statement. Known CKD. Creatinine 2.3. 38-year-old lady with hematuria. What's the first thing that you say? What's the first thing that you think? Will you think of urology or will you think of nephrology?
Nephrology.
Nephrology. Very good. So what is that nephrological condition? Which can happen in a 38-year-old lady who is known CKD now, 2.6.
Can be small kidney,
Small kidney
PUG obstruction.
And you said nephrology, no? Nephrological condition. Urological condition. You already told us about IgA nephropathy.
Yes, sir.
I have already told you about RPGA.
Sir.
Anything else?
Cystic diseases.
Cystic disease. Very good. Now you are coming slowly into the Karamura. What cystic disease?
Autosomal dominant polycystic disease.
Yes. Can't she have? Can we get not hematuria? That is all dog. 38-year-old lady. Created 2.3 at the age of 38. What history now? What's the next history?
Previous history of hematuria.
Forget previous history of hematuria. It's the first episode. What's the most important history last?
Urine output is on the.
Cholo yaar, urine output. Most important history. You said autosomal dominant. What does it mean?
Mutation at a single.
What does it mean in terms of history?
Family history.
So what do you ask?
Very similar history in the family.
What means similar history? What is a similar history? When you ask a question, sorry, it must be very specific. It must be very specific.
Any kidney disease in the family.
Yes, kidney disease. In who?
In the first degree relatives. Family.
At first degree. What about brothers, sisters, siblings?
Yes.
Yeah, very important. Okay.
Hello?
Yes.
Sir, your voice is not audible clearly.
No, I was asking you about, can you hear me now?
Yeah, better, sir. So what do you think the CKD is due to?
You're asking me or?
No, no, sir. I'm asking
I just,
whoever is answering.
I don't think you heard that bit of the questioning that I did for them. And the CKD, I said that a young lady, what's the important history you will take? And he went on to, with some prodding, he took polycystic disease and then autosomal dominant polycystic disease. So we stopped at that when he said you can't hear. So that's where it was.
Okay. No, I was asking him, what do you think the CKD can be due to in addition to the things which were discussed?
Ma'am, it can be because of a previous history of any disease, can be small kidney, or any past history of, or it can be chronic pyelonephritis.
No, the history is very important. There are 100 causes, like
Yeah,
what
there
you're
are
talking.
100
But in this
causes.
situation, with this creatinine of 2.3 and with the history of hematuria with this PLS, can there be any other reason? Let us look at a urological cause. Urological cause.
There can be
You mentioned it 2 minutes ago.
cystic disease.
Not cystic. Cystic disease, we finished. Polycystic disease. Anything else? I said urological cause. Where the creatinine is 2.3. You're talking a small kidney. Expand on that line. Expand on that line.
It can be because of small kidney, or it can be because of
What is this term known as small kidney?
Atrophic kidney.
atrophic kidney. Will be
Small.
Not
Small.
So bilateral small kidneys or bilateral atrophic kidneys, you mean? Because creat is 2.3, right?
yes,
It
ma'am.
can be unilateral disease to account for creat 2.3.
Always remember that when somebody has got an elevated creatinine and just out of the blue, are we looking at a person who's got a single kidney which is defective? Are we looking at somebody who's got both kidneys defective? Or we are looking at a person who's got one kidney only, which is defective, nothing on the other side. These are things that know on kidney.
So it has to be
Hematuria.
either
That's it,
bilateral
only.
disease or a single functioning kidney with some disease.
Some disease.
Either
Yes.
nephrology or urology,
Yes, ma'am.
right? So if it is a urological cause, what are the conditions which can present as CKD at the age between 30 and 40?
And can present as hematuria.
And female patient. क्या हो सकता है? हाँ?
Anybody else?
Cox नहीं है. Why?
See, there is no symptom of Cox here.
There is no symptom of Cox. Yeah.
There is no symptom of pain. One of the conditions which does this
Reflux
is
disease presents as CRF in the age group 30 to 40.
PUJ obstruction is one condition where they can present for the first time as hemophilia. They need not have pain. Alright? So we are looking at first single kidney, borderline obstruction, going on for a long time. First time present as hemophilia. Keep thinking of all the conditions which can give rise to this. So work out in an algorithmic fashion in your mind as to how things are and then work it away. Okay.
Past history. Patient is operated case of augmentation cholecystoplasty with a left nephrectomy for thimble bladder. Secondary to tuberculosis 25 years back. The documents are not available. Patient underwent endoscopic ablation of bladder growth 1 year back at private hospital. No history of clean intermittent self-catheterization.
Are there any details available regarding the endoscopic ablation of bladder growth? Like how many growths were there, the size of the growth, the location?
No, actually, they have not mentioned all this, but only reports available of histopath report is available.
What was the histopathology report?
What do you think will be the histopathology report, sir?
Patient underwent endoscopic ablation of bladder growth 1 year back at private hospital. Sir, it has been 25 years since augmentation cholecystoplasty.
Very good.
It could be adenocarcinoma also of the bowel segment which has been used.
Very good. What else should it be?
Urothelial carcinoma it can be.
So there is. So when you asked about location, what was the reason you asked for location?
So adenocarcinoma usually would be like it's a augmented bladder. So if in the augmented segment, I mean
Where
the
will it be?
dome, trigone.
There's no dome, there's no trigon. The blood has been augmented.
Base of blood.
Base of the blood. Which is the vulnerable area? It is the junction. It's a junction where the bladder is anastomosed, where the bowel is anastomosed to the bladder. Every time when you do a ureterosigmoidostomy, you have minds too, same problem. It's there. It's at the junction where the ureter joins the bowel. So it's a junction where the bowel joins the bladder. That's where it is. And that's where it is adenocarcinoma. Alright? So now case is closed. No need to think of all the other things. But how are we going to move forward? So what is the biopsy report you have to know?
Personal history. A patient consumes mixed diet, bowel habits normal, denies addiction, regular menstruation, and she is married with one live issue. Family history, no significant family history. No history of any malignancy in the family. General examination, patient is averagely built and nourished, ECOG score of 0, afebrile, pulse 82 per minute, blood pressure of 112/76 mmHg, no pallor, icterus and pedal edema. Examination was normal.
No scars. No scar in the abdomen, huh? How was his operation done?
Yes, sir. Hello, sir.
You said there is no scar in the abdomen. So I'm wondering how the augmentation and nephrectomy was done 25 years back when the robot and other things did not exist. This is what is called autopilot. No. Without thinking.
Sorry, sir.
What, man? Yeah.
Creatinine is elevated, so
Yes.
2.3, which is
Yeah.
a known case of CKD. Plus the
What
other
else is elevated?
alkaline phosphatase is elevated.
Why is it alkaline phosphatase elevated? What else is wrong here? What else is wrong here? You can't look at something. Unfortunately, all these labs will, any abnormal, they'll put one black circle or black mark around it. Here they have not put that. What else is wrong with this report?
Hemoglobin is 9.6.
All right. What's the explanation for that?
Known case of CKD patient.
Okay. Any other reason for low hemoglobin?
Malignancy itself.
Bleeding. Bleeding. All right. And
First reason being, second reason being menstruating. Third reason being the youngest will take CKD. And nutrition.
so why is there low hemoglobin in CKD? Right. Okay. And what type of anemia is it usually?
Microsecond.
That is iron deficiency in renal failure. So usually normocytic now. If there is an associated iron deficiency which can happen, then you get hyperproblemism. Otherwise, what's wrong with the calcium? You didn't look at that? 6.9. What could be that? Now, can you correlate 6.9 calcium, high alkaline phosphatase together? Some other test is missing here. Anyway, with these two, can you tell me what else could be wrong with this lady?
Maybe she has
Lady. Augmented bladder.
metabolic abnormalities.
Metabolic. So what is that?
Hypotonic metabolic acidosis.
Okay. So as a result of that, what happens?
Anemia can be explained by
No, forget anemia. Don't suddenly sidetrack and go to anemia.
calcium will be
Wait. You said hypochloremic metabolic acidosis. Is there hyperchloremia here?
also.
No. More than 110 is supposed to be hypochloremia. 108.
Yes.
It's all right, but doesn't matter. We leave that. But tell me, what is the mechanism for this? No? What does acidosis do to bone? What does it do?
Chronic acidosis will cause
This is what happens particularly in women who have got fragile bones generally to start with. When you have an augmentation done more than 25, 30, 40 years, all of them will have problems with the bones. They will all get bone disease, osteomalacia, low calcium, high alkaline phosphatase, all right? And then they'll have difficulty in what? Difficulty in what? As a result of that. Which is the bone that is maximally affected in this? Weight bearing. Which is the weight bearing bone? Which one?
femur.
So today the mic is not clear, sir. Both of you, your voice is not clear. We could just hear patches of what you're saying.
No, I'm asking some physiology because this case is typically only that, nothing more. I mean, there's every finding is here which is very important. So we're trying to get to the basic stuff here. We are looking at the alkaline phosphatase which is elevated. We are looking at the calcium which is low, and the effect of this in a patient who's had an augmentation. So you had osteomalacia, and this is pelvis. There is a classical radiological sign. What is it? Of osteomalacia. That's why I said, how will she be? She'll be walking with a waddling gait. Why? Because the pelvis is, what's the classical X-ray picture? Have you seen the Mercedes Benz? The emblem. Or the tri-radiate pelvis. Huh? This is what in radiology you would call an Aunt Minnie. We'll explain that term sometime back.
No,
Okay,
volume
so it's a
का
classical X-ray picture.
वहाँ पे
Can you hear me?
नहीं
Sujata?
not here sir.
Don't know what the.
It's in between it becomes clear, then few words are lost. Anyway, it's okay, sir. We are okay. So, would you like to have any imaging?
Yes, ma'am. She's having hematuria.
Speak little louder. I think you have trouble with this.
Yeah, you have to
computer.
speak little louder.
You have to tell that guy to come. Just something wrong.
And first, I will ask for ultrasonography.
You would ask for an ultrasound?
Yes, ma'am.
Why?
Ultrasonography with
Why would you ask for an ultrasound? The history told you left nephrectomy is done. History told you that there is a mass in the bladder with biopsy is done.
Yes, ma'am.
So what ultrasound is going to tell you?
Go
Extra. Once there is a mass in the bladder, what you want your radiological investigation to tell you what details?
It is suspected to be the patient already had a tumor. 1 year back, she had undergone ablation. So now I would ask for imaging to look for any.
No, you tell me the first answer to my question. Whenever there is a mass in the bladder which was biopsied 1 year ago, and you want a radiological investigation to give you what information?
Ma'am, the TNM basically the tumor characteristic, whether it's
Right.
invasive.
So you want to know whether the tumor has recurred, whether it is what is the TNM staging of the tumor. So will an ultrasound tell you that?
No, ma'am.
Then why ask for it?
I'll go for
Because
CT.
it's not a case of hematuria where everything has been normal and there has been no history and you do not know whether the tumor is in the bladder, ureter or kidney or somewhere else. So it's not that, no? You already have an inkling in the history that it is a bladder mass.
Yes, ma'am.
Okay. Show him the CT which we have. So
Next
anyway,
slide.
we'll show you cytology was positive and was suspicious for malignancy.
Yes,
Next.
ma'am.
This is the report of Tata Hospital and the previous report was of another hospital.
Next slide, please. Next slide, please. Next slide. So you can see the right kidney having mildly dilated pelvis, the upper ureter. Next slide, please. Next slide. Next slide. Next slide, please. Yes, sir. Please go to the previous slide.
He wants the previous slide.
Previous slide, please. So you can see the augmented bladder, sir. And in the anterior region, we can see a growth.
First see all the slides. First see, don't be in a hurry to comment. Show him
Yes,
all
sir.
the slides.
Next slide. Next slide.
सब बता दो.
Next slide.
हाँ, see, you didn't wait.
Oh. Next slide, please.
Next slide बताना. Next बता दो.
So, in the CT scan, we are able to see one large growth in the anterior part.
Can you hear him, Sujata?
Yeah, sir, it is a muffled voice, but yeah, better than before.
Ma'am, we can see one growth in the bladder, in the anterior part of the bladder. The bladder is distended. Can you please show me that slide, please?
Is it one growth or many growths?
I don't know who is answering. What is your name?
Ma'am, Dr. Soumya Patnaik.
So Soumya, I should wait till everything is shown to you.
Yes, ma'am.
Okay. So you'll get a surprise otherwise. बोलो अभी. You wanted information about TNMN. So tell all that information. Yeah, are you saying something?
Not yet. He's not saying anything yet.
Okay, then I'll ask you something. Why is the kidney hypertrophied and create 2.3?
Ma'am, it's a single kidney, so the functioning kidney will be hypertrophied.
Yeah, but contralateral kidney is hypertrophied, but why is create 2.3 then?
And there was a little bit dilated pelvis was seen, probably because of the obstruction.
Pelvis, you are finding it to be dilated here? Okay, maybe you can't see very properly. Okay, a comment about the bladder, please.
It's an augmented bladder, it's not symmetrical in shape. We can see some the growth we can see. So the anterior part of the bladder, we can see some growth.
Go up. Show him.
Let's go back to that original question that
Yeah.
Madam. Why do you think the creatinine is 2.3? Is there really an obstruction to the kidney?
No, sir.
Then why is the creatinine 2.3?
Kamlesh is saying hyperfiltration injury.
Hyperfiltration injury. Hyperfiltration occurs in which condition?
Single kidney cases.
Single kidney, but in which situation? Diabetics. Diabetics are more prone to hyperfiltration. But this lady, is there something more glaring in her that can account for this rise of creatinine? And is it expected?
Also said she is not doing CS.
Obstructive.
No, she's had a bowel segment, isn't it? This is the consequence of augmentation. Bowel segments in the urinary tract are notorious for producing deterioration in renal reserve over time. She is only 38. 25 years ago, she was 13 years old. And she had that operation when she was young. One kidney ablated. So every load was there on the right kidney. And on top of that, you lug out augmentation. It's a double whammy situation, isn't it? No, pregnant. The question now is there additionally some medical problem like hypertension which has been missed? Huh? Is there a diabetic situation which has been missed? We don't know. So medical conditions on top of this add insult to injury. But basically, you don't need to have obstruction. And as Dr. Bobby mentioned, she is not doing CSC. So what happens if you don't do CSC? There is no back pressure here. Where is the back pressure? There is no back pressure. Bowel. This is bowel, no? So what will happen if you don't do CSC? Don't we say overnight drainage for all these patients who have bowel segments and they don't do it because it's a bit of a pain? Huh? Why do we say overnight drainage?
Purpose to keep the bladder in.
Hey, Baba,
Yeah,
remember?
why is overnight drainage advised?
Huh? Why is overnight drainage advised?
It's
See, bowel
convenient
is
to
bowel,
put the
it will
catheter
absorb
at
or
night
disappear.
and at the same time
Wherever you
12
put it.
hours or 8 hours of continuous exposure of the bladder.
This is what is going to happen.
The bowel
More exposed to the medium.
doesn't happen.
Urine, there will be stasis in the night. Urine get absorbed. Urea gets absorbed through the Krebs citric acid cycle. Urea converts hydrogen release, ammonia goes on, round and round and round, knocks a single kidney back. Slowly over time, renal failure. That is why we insist that these people at least do overnight drainage if they are not doing CS. And this is what is likely to happen if you do an operation at a young age. Why do you think all these young girls who have come here, I am not advising them to do augmentation. Live with your bladder, even if it is 20, even if it is 150 cc capacity or 200, go to the toilet. But to add bowel to this in a young person is going to be disaster, no question. You've seen enough, I've seen enough of that to land up in this problem. It's not unusual. But what is unusual and what is not mentioned in the books here is that TB does not occur in young people. Because it takes so many years. That philosophy. So in India we are seeing this. At the age of 13 TB. That means what age you have got TB? The next question you want to ask is, was it transmitted through the placental barrier? Did the tuberculosis go from the mother to the child? So these are issues that have to be discussed. So this is the classical case. This is clinical medicine. This is clinical urology. Everything is there in this case. All your renal physiology, renal anatomy, everything. What you should do, what you cannot do, what is the consequence. More importantly now is the future treatment of these ladies.
Yeah, so can you describe the tumor and tell me the T staging?
So we
Yes,
can see-
Soumya?
Yes, ma'am. We can see a growth in the anterior part of the bladder.
When you talk in the mic, we can't hear you.
Ma'am, there is a growth in the anterior wall of the bladder. And
Anterior wall.
cycle extension also we can see little bit of extra cycle extension.
No, we can't hear you at all.
I think we need to get an external mic, connect those speakers, get that fellow to connect it and put it, because obviously this mic, the computer mic is not hot enough. Old computer was, mic was better.
Okay, so there is a tumor, there is a mass in the bladder. Where is it situated?
Anteriorly it is situated.
Yeah, you see the skin there, you see the scar mark, probably maybe the umbilicus or wherever it is. And you see this growth sitting there. Okay? And apart from that, you see one cut as though it is just on the wall. But in the next cut, you see a little bit of irregularity in the wall and some little bit of contrast appears to be outside of that. So obviously there is some infiltration of this contrast into the interstices of the abdominal wall. Remember, there is a scar there. Whenever there is a scar, tissue planes are not normal, they all open up.
Specimen का photo add किया है? नहीं.
Things go wherever they want. So there is some degree of infiltration of the serosal surface. The bowel also has serosal surface, extending outside.
Okay, anything more you would want to tell?
Any nodes there, obvious nodes?
Any notes?
Now, will you get the nodes which are there as TCC bladder in this situation? Or will you get nodes which are for bowel?
ऊपर की cuts में बता देना जरा.
Yeah, that's very important.
बता. Patients में तो patient में तो थे.
Sujata,
Yes sir.
I was asking him, what will be the nodal description here?
Yes sir.
It won't be the bladder. It won't be like TCC of the bladder because you got bowel. The bowel will remain, it's there, mesenteric. So you'll have to go and look at it, whether there is mesenteric involvement at all or not.
This patient had nodes above the bifurcation of the common iliac.
Yes, so that's where it is. It's all in the mesenteric.
Obturator were okay, nothing there, nothing in perivesical. Here also it's not seen very clearly, but she had nodes above bifurcation of common iliac, para-aortic and inter-aortic cable. Not even mesentery, sir. It was little funny. And
So what did you do?
these cuts are not showing, but the ureter was massively dilated.
Oh, I see. There is some dilatation here. I can see one cut here, but that's probably.
Yeah, yeah.
So.
So,
What
okay,
you
now
gonna do?
we have told you all the findings. Now tell us what to do.
You have to go for cystectomy.
You want to do any metastatic workup?
Yes, ma'am.
Chest X-ray?
Yes, ma'am.
No, we can't hear you, Soumya.
Yes, ma'am. Metastatic workup has to be done. We'll
Okay.
go for,
Have you done metastatic workup?
You go to the PD. OPD.
His alkaline phosphatase was elevated, na?
yes, ma'am. Go ahead.
But liver looks normal. So this biopsy report from Tata is suspicious for adenosine. You want to repeat it?
Everything is suspicious. Cytology is suspicious. Tumovalis, one fellow said, adenocarcinoma suspicious. What will you do?
Do a scopy.
Okay, you will do a scopy and that? Huh?
I'll try to take a biopsy.
How do you do that?
You are.
You would prefer to do, but bladder growth biopsy they said. That means they must have done a pinch biopsy or something. I don't know. They must find out what is the technique of biopsy that was done here. if they have some idea. Otherwise, you may have to get a resection biopsy. Suspicion is not equal. Suspicion of adenocarcinoma. That means the pathology is not put as like on the annual. You just say, oh, maybe, and then other fellow said tubular village. That was suspicion of malignancy.
Go for.
So if you want to do anything in the exam, if you're right, you say boldly. So these are all only suspicions. Although this looks like a malignancy to me, but if I have to do something for this patient, I will do this. You have to be bold up front, because that's what you tell the patient. He will ask you, "No, but you want to again biopsy?" First question, again you want to do biopsy? You will ask 100 times. You will ask 100%. Then you have to stand firm. Yes, I want to do biopsy. And this is the type of biopsy I will do. What is the risk of TUR biopsy? Yes. Because it's foul, isn't it? So, can be done. You will have to bite that bullet. If you want to take a biopsy, you can take a resection biopsy. You know how. Okay.
Okay, biopsy is adenosine.
Now what do you do?
Adenocarcinoma.
Lata, I'm going to the OPD. Late for me.
Okay, sir.
You carry on. But this is an interesting case to discuss the future of this lady. Can we discuss that in the next class for half an hour?
Okay, sir.
Because creatinine is 2.3. You discuss the rest of it, and then we'll take in the next class the first 15 minutes. I will ask some questions on this, on the future of this lady.